Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. So we have learned about the two pathologies of lung parenchyma, that is alveolar opacification and collapse. Now we learned about the another pathology, that is interstitial opacification. Now we will begin with the name of Allah. So interstitial opacification, and what kind of interstitial opacification is it? So this is not easy to make out on chest X-ray alone. For this, HRCT, high resolution of CT scan, is the modality of choice. We should keep this in mind. Okay. So what is the pathophysiology? The scaffolding or the interstitium. What is the interstitium? Suppose this is alveoli and this is another alveoli. So in between these two alveoli is a interstitial space. Okay. Here you will see blood vessels running here. Okay, and nerves running here. Blood vessels and nerves running here. So this is known as the interstitium of the lung. Okay, this is not in the alveoli. Okay, this is in the interstitium. Okay, so the findings on chest X-ray are minimal on chest X-ray. The findings of interstitial opacification is minimal on chest X-ray. That's why HRCT is the modality of choice to know interstitial opacification and to know the cause of the interstitial opacification. So what can be the patterns of this interstitial opacification? Three patterns: reticular lines, nodular means dots, reticular nodular means lines and dots. So it can be like network like lines, or it can be lines with dots. So you will have network like lines and dots. It can be mixed. Okay, combination of lines and dots. So net like pattern is seen in early fibrosis if it is fine, or if the lines are coarse, then it is known as honeycombing. Honeycombing is nothing but the hexagonal type of line pattern. Okay, you see in honeybees, they accumulate the honey in this pattern, no? So that is honeycombing. So in this pattern you will see coarse lines, and here you will see fine lines. So that is fibrosis, early fibrosis, and coarse, that is honeycombing. So where you will see that type of pattern usually you see in pulmonary fibrosis, chronic lung diseases. For example, when there is rheumatological involvement of the lung, or after a viral pandemic like COVID-19, you will develop interstitial lung diseases, no? Like idiopathic pulmonary fibrosis, non-specific interstitial pneumonia like things. So you have this pulmonary fibrosis. So you will develop a restrictive pattern of lung disease when there is pulmonary fibrosis. Dots. So you will have innumerable small dots scattered throughout the lung fields. So this is seen in miliary tuberculosis and sarcoidosis. Most common in India is miliary tuberculosis. Okay, and sarcoidosis is also one thing. Reticular nodules mix lines with dots. So this you see in carcinoma, lymphangitis, carcinomatosis, mixed reticular nodules. So below images you can see. Okay, this is fine reticular pattern, this is coarse reticular pattern, nothing but honeycombing, and this is nodular pattern, and this is also a linear pattern. These are nothing but curly B lines. Curly beans are known as curly beans, B lines. Okay, so you can see here in this one thing, if you want to see these things, no, this interstitial opacification, don't concentrate upon the ribs, concentrate upon bilaterally on the chest X-ray. You concentrate upon the spaces between the ribs, then you can make out this interstitial opacification pattern. So you see these four patterns. See here, this is a linear, these are the ribs. Okay, these are the ribs. This is one rib, this is second rib, and this in between these ribs you can see these lines. Okay, so this is a reticular pattern, and in this you can easily make out this is the one rib, this is the second rib, this is the third rib. So small dots you can make out, small dots. So this is nodular pattern which can be seen in miliary tuberculosis, and this is in fibrosis. And this one is, I think, reticulonodular pattern, reticulonodular pattern like thing. Okay, just meshy network like thing. You remember this network like thing. And this is purely nodular, micronodular pattern, and here it is honeycombing like thing. See, it is honeycombing pattern. You can see this honeycombing pattern like thing. Let us see the headings of these X-rays. So chest X-ray A. So linear pattern, curly lines, network of lines caused by thickened connective tissue septa in a patient with cardiac failure. So mainly you see these curly B lines here at the periphery of the lung, parenchyma on the chest X-ray. Straight lines you can see in pulmonary edema, thickened septa because of leakage of fluid from the blood vessels in the interstitium of the lung due to increased hydrostatic pressure. Nodular pattern you see in, this is the nodular pattern, miliary tuberculosis for example, or okay, for example, okay, then this is reticulonodular pattern. You are seeing dots and fuzzy like opacification you are seeing in between the ribs. That is nothing but lines with dots. So you see this in carcinoma patient which is obstructing the lymph flow. Okay, lymphangitis carcinomatosis, that is called as. And the D is nothing but the coarse. I said no, this is honeycombing, coarse network like pattern. So coarse network like pattern, coarse network like pattern. So these are the things you can see in chest X-ray. So remember this table, that's enough. Okay, and common causes for that. One more chest X-ray. See, in the chest X-ray you concentrate in between the intercostal spaces, you concentrate in the intercostal spaces, you will and compare it with the other side. You see it is, if I zoom this looks like reticulonodular. Actually this looks like reticulonodular if we see, but in the description it is given as micronodular pattern, but it looks like reticulonodular pattern. Okay, reticular. So mainly that means the interstitium of the lung is involved. The interstitium of the lung is involved here. Okay, and these are the memory shadows. And trachea, you see it is equidistant. Exposure is also okay. You can see it is underexposed actually, because so much of thoracic vertebrae you are able to see. So underexposed chest X-ray, not rotated, and inspiration. If you see the inspiration, if I count the ribs, 1 2 3 4 5 6, okay, inspiration is good but underexposed. And this is micronodular pattern. So same patient CT scan you can see here. So bilateral. Now here you can make out it is nodular pattern, bilateral nodular pattern. So it is a case of miliary tuberculosis. Okay, whenever there is interstitial opacification and the patient is symptomatic, always remember one thing, that ECG, X-ray, CT scan, MRI scan, or any other investigation, you need to correlate with the patient symptoms. If you give a decision without correlating patient symptoms with the investigations, then you are doing a blunder thing. So always treat the patient, not the reports. Always treat the patient, not the reports. So any investigation, you need to correlate with the patient symptoms. Okay, this is a very golden point to remember. So you may get patients who have interstitial, whose chest X-ray look like interstitial opacification like thing, but the patient doesn't have any breathlessness, any past COVID like it is nothing. You will see no symptoms will be there. So you can't make out any diagnosis from that. Okay, so that was interstitial opacification. Now we will learn about the nodular opacification. This is very important because dangerous things can be hidden in this nodular opacification like carcinoma. So it is called as nodule when it is equal to or less than 3 centimeter, and it is called as mass when it is more than 3 centimeter. It is called as mass, and when it is more than 3 centimeter, it is called as nodule when it is less than or equal to 3 centimeter. So the nodules can be divided into solitary pulmonary nodule. So I have made a video on this solitary or incidental pulmonary nodule, a detailed video on this, how to follow up such patients with the CT scans. In detail video I have made in the topic of cardinal manifestations of respiratory diseases. You can go and watch for that video if you want in detail information about this. So other thing is multiple pulmonary nodules. One is single nodule, one is multiple nodules. So we need to differentiate. So solitary pulmonary nodule, so it is a common and it is a critical finding. The goal is to distinguish between benign versus malignant. Okay, so what are the benign features? Presence of fat within the nodule, likely hamartoma. Popcorn or central dense calcification, so fatty content calcification, so it can be granuloma or hamartoma. Or stability over more than 2 years, or the volume doubling time is, what is volume doubling time? Again you need to watch that video, more than 500 days. then it is benign. So these are benign classification patterns. So presence of fat, calcification, or volume doubling time more than 500 days, or stability for more than 2 years. What are the malignant features in this? Spiculated margins, not soft margins, spiculated margins, or lobulated margins, or partly solid or subsolid appearance. For example, GGO is nothing but granulomatous polyangiitis. In patients with granulomatous polyangiitis, you see this type of nodules, partly solid or subsolid apparent. Okay. Or rapid growth. What is a rapid growth? Volume doubling time less than 400 days. So these features suggest malignant nodule. So management is according to the Fleischer Society guidelines. Again, these are described in that video. Okay. We are discussing chest X-ray, so I'm not going into depth. So multiple pulmonary nodules, what are the differential diagnosis? What are the differential diagnosis? Metastasis is the most common differential diagnosis in multiple nodules. Metastasis. Okay. Next is septic emboli. Septic emboli. So somewhere sepsis, and through the blood vessels it is coming to the lungs. So multiple septic emboli. Fungal infections, fungal balls. Okay, fungal balls. Bond. And autoimmune diseases like granulomatous polyangiitis or rheumatoid arthritis, which affect the lung. So this is a vasculitis, and this is a rheumatological disorder. Autoimmune disease, granulomatous polyangiitis and rheumatoid arthritis. So these are the important differential diagnosis of multiple pulmonary nodules. Number one is metastasis, the most common. Second is septic emboli. Third is fungal infection. So we can remember this as like this. So one is metastasis. Second is bacterial infection, nothing but septic emboli. Third is fungal infection, nothing but fungal balls. And fourth is autoimmune, nothing but inflammation. So this is infection, and this is malignancy, number one. Malignancy, and these two are infection, and this is inflammation, nothing but autoimmune diseases. 3 I's: increased proliferation, infection, inflammation. So these are the 4 important differential diagnosis of multiple nodules. So how will be the metastasis? They are typically well defined with varying sizes. Cannon ball lesions, they are called as cannon ball lesions, and they are predominantly present in the lower lobe. Classic for hematogenous spread of malignancy. Granulomatosis with polyangiitis, GPA. You will see cavitary nodules or masses. Nodules less than or equal to 3 cm, masses more than 3 cm. Classically, autoimmune is the cause. Metastasis, predominantly they are present in the lower lobes, and cannon ball like appearance they will have. Varying sizes, not same sizes. Okay. So those are the differential diagnosis of pulmonary. Remember this table. We will see the chest X-rays now. Okay. So lung nodules are rounded opacities located in the pulmonary interstitium. Okay. They comprise pulmonary nodules less than 3 cm and pulmonary masses more than 3 cm. Nodules less than 6 mm in average diameter are called micronodules. Okay. Less than 6 mm is micronodules. According to the Fleischer Society glossary, pulmonary nodules can be solitary or multiple. This important. The prevalence of lung cancer increases with the size of the nodule. So it is less than 1% if the size is less than 5 mm. It is 1 to 30% if the size is between 5 to 10 mm, and it is more than 10 mm if the size is 30 to 80% is the probability if the size is more than 10 mm. So in the FSH, if any nodule which is more than 6 mm, no, you need to follow up the patient. If the patient has the CT scan now, you can previous CT scan, you get a new CT scan, and between these two CT scan, by taking these two CT scan, you will calculate the volume doubling time. If the volume doubling time is less than 400, then it is considered as malignant. If that is more, or if it is more than 500, then you called as benign. So less than 400, again according to if it is less than 400, likely it is malignant. Again, there is when to monitor, when to intervene, when to do bronchoscopy. That is there in the video of solitary pulmonary nodule. Okay. If the patient doesn't have any CT scan, so you will wait for 3 months and you will do CT scan if the nodule is 6 to 8 mm. So that second CT scan and this present CT scan, you will calculate the volume doubling time, and according to that volume doubling time, you will further follow up the patient. Okay. I will take this downside and this one here. Okay, so we can see here, so this is a mass, these are nodules, this is more than, this is less than or equal to 3, but this pointed thing is there, no, this is micronodule, so this is macronodule and this one is micronodule. This yellow one is macronodule and this green one is micronodule, but both are nodules and this is a mass. Okay, okay, so now you will see this chest x-rays, very important chest x-rays. So now first we will come from basics. So see the rotation, there is no rotation, see the clavicles, exposure is okay and inspiration is also okay, 5 to 6 is you are able to see. I think it is hyperinflated chest x-ray because domes of diaphragm are flattened and the spaces between the intercostal spaces are very large. So I think it is hyperinflated. So let us see whether it is hyperinflated. So this is 1, this is 2, this is 3, this is 4, this is 5, this is 6, this is 7, this is 8. Yes, it is hyperinflated x-ray. Okay, now you just divide the chest x-ray into upper zone, middle zone and lower zone. So you compare this to this, nothing is there, and you will see the carina. Okay, this is higher and this is lower. Cardiac is also okay, no cardiomegaly is there. You can see the aorta, you can see the pulmonary arteries here. Okay, but one thing, this as this arrow is pointing, you here you can see a soft border nodule, so it is likely a benign lesion if it is not more than 6 mm in size or not more than 5 mm size. It is likely benign, the A one. So let us see in the description what it is. Likely it is benign. So lung nodules and masses. Yes, I said no. It is a solitary lung nodule. Hamartoma. What is hamartoma? Abnormal arrangement of cells. Sorry, normal arrangement of cells at abnormal place. That is hamartoma. No, normal arrangement of cells at abnormal place. So you have blood vessel cells which are deposited in the lung. So that is hamartoma here. Hamartoma of the lung. So this is a benign nodule. Okay, now we will see this, decode this x-ray in a similar way. Again here also you can see the intercostal spaces are very much the left side actually. The intercostal spaces are very high, increased in diameter. Let us see, say 1 2 3 4 5 6 7 trips you are able to see, not more than 7. Maybe it is hyperinflated or nothing, you know. So here you can see it is overexposed, so you are not able to see, just able to see the chest x-ray, and the patient is rotated to the left side slightly. Okay, that's the first technical quality. Okay, so this is the aorta, this is the left ventricle, and this is the left atrium, right ventricle. Okay, but the thing again, you should what do you call, draw the zones of the lungs. Okay, these are the zones of the lungs. Okay, now in the, you compare this and this. So here you can see a mass, you can't say this as a nodule, mass like thing, it is very big in size, and you can see here spiculated margins. Okay, mass like thing, and we are not able to make out these asterisks which are marked, but according to they have, as they have marked, so maybe here there is again 2 nodules are there. Okay, and as such there is no collapse, consolidation or interstitial opacification, nothing is there. You can see a mass with margins, so likely it is malignant nodule. So let us see the description now, what it is. B. Okay, B. So see, it is a lung mass and lung cancer. It is squamous cell carcinoma with enlarged paratracheal stripe and hilar enlargement due to lymph node metastasis. Okay, now, so because we here there is a asterisk, that's why we are confused whether there is, you can see a hilar fullness here. Hilar fullness, by hilar fullness I mean that more whitish appearing hila, but not like a will not have a characteristic border like thing there, but fuzzy and fulling hila you can see. So that's this is because of lymph node enlargement, and this is at the periphery of the lung, so it is squamous cell carcinoma malignancy. Okay, here also you can see somewhat filling of the hila, you can say. Okay, this is a parastracheal stripe, see it is enlarged. Okay, So here maybe this may be the right paratracheal lymph nodes which are enlarged, and this is the hilar lymph nodes which are enlarged. So the main thing is this mass we need to detect. Okay. So next thing is to send it to CT scan and you will make the diagnosis. Patient will have features. We'll go to the next chest X-ray. See, now easily you can make out this. This is interstitial opacification. No, you see the interstitial intercostal spaces. So this is nothing but nodular, or you can say reticulonodular type of thing which we are seeing. Okay, and chest X-ray is underexposed because ribs you are make out vertebral. Sorry, vertebra you are make out very clearly from the heart. So, and it is normal inspiration and it is not rotated, but you are making out here both sides micronodal pattern. Maybe it is miliary tuberculosis, or it can be fibrosis is honeycombing or reticular pattern, but it is reticulonodular pattern. Most common cause is miliary tuberculosis. We have seen the chest X-rays. These are these things. These are the breast shadows. Okay. Let us see what is multiple micronodules. So micronodules are nothing but less than 6 mm. They are known as micronodules. So this is miliary tuberculosis. Okay. So now you see here this X-ray. How is this X-ray? You can see whitish with varying size, cotton ball-like opacity, cannon ball-like opacity. You call no? Cannon ball-like opacity, and these X-rays are very typical. After seeing these X-rays, if you see a similar X-ray in some other patient, you will immediately say that this is the diagnosis of this X-ray. Okay, very typical, very highly yielding X-rays these are. Okay, so this is metastasis. Okay, this is metastasis to the lung. See, they are aggregated more on the lower lobes, lower zones of the lung, but upper zones they are there, but not that much they are present. Then when compared to the lower zones, in the upper zone, the density of these metastasis is less. Again here, see, you can see. So we will go step by step. No, so you see it is equidistant, not rotated. Patient is not okay. Exposure is also okay. Inspiration is also okay, because spaces are okay. By seeing, if you have got experience, then by seeing you will say whether the tachycardia is right or not. Okay, now you compare the zones, you make the zones. Okay, zones. So here you can see a mass, you say it as mass, and here you can see a cavity in the mass. Similarly, here you can see a mass. Okay, and here also you can see a multiple nodules you are able to see with different sizes, but this thing is notable. Okay, so this can be fungal infection also, because in fungal infection also you have cavitatory masses, or it can be abscess also, but we don't know here. But abscess is usually single, not multiple. Septic emboli, as we have discussed, no multiple. What are the different things? Number is metastasis, it can't be metastasis. Number two, septic emboli, yes, it can be septic emboli, we don't know. And third, fungal balls, it can be, yes, fungal balls, they also present like that, or it can be autoimmune also. Let us see what is the diagnosis. So perfect diagnosis you can make only if you send the patient to CT scan. So E, multiple nodules and cavitary mass. Yes, cavity is there. Gas filled mass with thick borders. This is a patient with granulomatosis with polyangiitis, formerly known as Wegeners graulamotosis, a type of vasculitis. Okay, so these are the chest X-ray you need to copy paste into your mind. Okay, you will have these things. Okay, any nodule, any mass, any micronodule like pattern. Okay, so nodule, single nodule, you need to follow up the patient. Multiple nodule, you will know what is the diagnosis. So again, same. No, this is the CT scans of the patient. See, you have sent the patient to the CT scan. So if the nodule is peripheral around the fissure, just adjacent to the fissure, like here you can see. So this is the fissure. This is the fissure. In the fissure, the nodule is present. That likely it is benign. It is a benign type of nodule. And if the nodule has triangular shape, if it has a triangular shape, like this is approximately a triangle, and in D, yeah, it is also a triangle like shape, then also it is benign. Okay, corresponding to intrapulmonary lymph nodes. Okay, so periphyseal location and triangular shape corresponding to the intrapulmonary lymph nodes. So that is a benign nodule. And if fatty content, which can be made out in CT scan like BEF, so this is the fatty content. You will get whether it is fatty content or not, you get in the a report from the radiologist, or if you know the CT scan very well, you will only make out that whether it is fatty content or not. E is here also, okay, and F here. Fatty content is nothing but some, because fat is water like, so blackish like thing, not that much, but it is what you call light gray like thing. Fat is light gray in color, okay, right? It is light gray, no? So you can say light grayish thing in these nodules. Popcorn calcification. So calcification is calcium, so it will absorb the rays, and it is white color, typical of hamartomas, fat content and popcorn calcification. So C and F. See here, this point whitish like thing, as these arrows point. So this is these arrows. So these whitish like things are nothing but calcifications, and fatty tissue is nothing but light grayish color in CT scan also and in X-rays also. Triangular, periphyseal, all these things are benign features of a nodule. Okay. Now we will see malignant nodule in CT scan. So what are the features? Scars, dot like, rather peripheral calcifications. Okay, you can see here it is dot like, okay, dot like thing. Spiculated margins, spiculated or irregular margins. You can see it, yes, here you can see spiculations, no, in A and F. Yes, here also you can see the margins are spiculated. Lobulated margins, here it is lobulated, okay, in B. Subsolid nodule, C. See, subsolid means nothing but whole nodule is subsolid, not in the benign nodule, the center part of the nodule is subsolid and the periphery is calcified. Okay, here it is opposite. It is central calcification, or the whole nodule is subsolid. Okay, just to differentiate, I will show that thing. Here you can see here in the center it is subsolid, center subsolid, but peripheries are not subsolid, and peripheries are calcified. In the malignant features, it is just opposite. So center it will be calcified, and instead of just center, whole nodule will be subsolid. So that is a feature suggesting malignancy. And spiculated margins, lobulated margins, subsolid nodule, part solid nodule, in partly solid nodule. Cavitation is also not a good thing in the absence of infectious scar or not in immunocompromised patients. Cavitations. Okay. Retraction of pleura or fissure is also a malignant feature. Retraction of pleura, just remember, or bubble like lucencies in F. Here there is a retraction of fissure. Okay. Just remember these features suggesting malignancy. What are the features? Scars, dot like, rather peripheral calcifications, spiculated margins, lobulated margins, subsolid nodule, part solid nodule, cavitation in the absence of infectious cause or immunocompromised state, retraction of the pleura, bubble like lucencies. So these are all the features of malignancy. Okay. See, this is one thing which so these are serial X-rays which are taken. So this is October 2019, October 2022, August 2022. This was the size, and see here it is increased to this much in how many days? In 215 days. VDT, not VDT is 215 days. That is nothing but less than 400. So it is a malignant nodule. Like that, you should compare two different CT scans. Okay, you need to follow that features society guidelines, which is you see, go and see that, watch that video. Okay. The next one is the benign nodule. See, here there is a nodule, but it is, what is the duration? Just see, it is 1020 days. So volume doubling time is more than 400. So likely it is benign nodule. No need to further follow up. Okay. Okay. So this is a last picture. Lung metastasis detected 2 years post the treatment of a head neck squamous cell carcinoma. A right apical upper lobe nodule and a right anterior upper lobe nodule in C and D were seen. Images B and D correspond to volume rendering reconstruction using an automated software volume calculation. We are reading chest X-ray, so we will concentrate on chest X-ray. Again, you see here same picture, no? The granulomatous, we have discussed the cavity inside, and here you see again here one. Okay, here, In lateral X-ray also you can see this is present in the middle compartment of the mediastinum, and this is the fissure. Okay, and you have some effusion here, some effusion here. So multiple pulmonary nodules located in the lower lung lobes and a cavitary mass in the right upper lobe in a patient with graulamotosis polyangiitis. Note thickening of the main right fissure. Yes, this is the oblique fissure. You can see it is thickened. Okay, this arrows point toward that. This is thickened. And due to interlobar pleural effusion also seen the left posterior costophrenic recess. So this is known as the costophrenic recess in the lateral chest X-ray. So normally here there is no fluid, but you can note here some amount of fluid here. Okay, due to fluid. Okay, so that's about the nodules. Okay, on the chest X-ray. Now this is the last part of the pathology of lung parenchyma. So hyperinflation. What we will have? Too much air and destruction of alveolar walls. For example, in emphysema patients. So flattened diaphragms you will see, hyperinflated lungs, more than 10 to 12 posterior ribs or more than 7 ribs anteriorly. Increased plaquishness. Easily if you want to make out the intercostal spaces, now they will increase in size. By seeing the X-ray only you will make out that it is hyperinflated. See here. So this is again what you call breast shadow. Okay, and you see the intercostal spaces here, they are very much far away from each other, so that is hyperinflated. Okay, and the diaphragms are flattened, so it is hyperinflated chest X-ray. This is the aorta, this is the pulmonary artery, this is the left ventricle, right atrium, right ventricle border. Okay, nothing other thing other than that, nothing is there. Okay, this is the X-ray of hyperinflation. Okay, that's all about the pathology of the lung parenchyma. From next video we'll discuss about the pathology of the pillar. Thank you.